present a paper. The title of the study is Sexual Dysfunction in Post-Stroke Patient, a cross-sectional study from a tertiary care hospital in India. So these are my co-authors. Coming to the introduction part, sexual dysfunction is common but often under-recognized or neglected after stroke. Prevalence of sexual dysfunction in stroke ranges from 20 to 75%. Stroke has multiple impacts on patients' sexual functioning, be it directly caused by the neurological lesion or indirectly triggered via other psychophysiological processes. And there is an increasing trend of stroke in India and affecting more young age people. So the primary objective of the study is to describe the profile of sexual dysfunction with respect to sexual desire, arousal, erectile function, ejaculatory function, orgasm among persons with stroke. And the secondary objective is to determine the level of satisfaction with sexual functioning among persons with stroke. Coming to the methodology, the study was conducted in Department of Neurological Rehabilitation, NIMHANS, Bangalore, and the study design is a single-center cross-sectional descriptive hospital-based study. And the inclusion criteria include persons of either sex, age 18 to 60 years, and more than 3 months since onset of stroke, with or without neurological impairment, and modified ranking scale scores 0 to 3. And the exclusion criteria is modified ranking scale scores 4 to 5, aphasia, impaired comprehension, presence of severe cognitive impairment, recurrent stroke, and not willing to provide informed consent for the study. So all stroke patients who attended the inpatient ward and outpatient clinic was approached consecutively to screen for the eligibility criteria, and only those patients who gave written informed consent in the designated forms were enrolled in the study. And semi-structured questionnaire was used to fill the patient demographics and clinical data, and the total duration of the study was 24 months. For the assessment of sexual dysfunction in females, 6-item female sexual function index was used, and total scores ranged from 2 to 30. And sexual dysfunction in males was assessed by International Index of Erectile Function with 15-item validated questionnaire. And to assess the premature ejaculation diagnostic tool, PEDT, was used. So this is the flow chart of how the data collection and data entry was done. And statistical analysis, categorical variables are described using percentages, and continuous variables described by mean and median. And associations between all the clinical and neurological variables with presence or absence of sexual dysfunction was done whenever feasible. So coming to the results, out of the assessed for enrollment around 144, and finally enrolled patients are 100, 85 males and 15 females. So these are the demographic data. So the total number of participants were 100, and the mean age of the participants was 49.4 plus or minus 7. So here we can see the clinical and neurological assessment data. Around 71% were having ischemic stroke and 29% having hemorrhagic stroke. And the clinical presentation, 60% had left hemiplegia, and around 30% had right hemiplegia, and 10% with ataxia. So the MRS score, Barthel index, and HADS scores were used. So the hypertension followed by smoking were the most common risk factors for stroke in this study sample. And the mean MRS of the study population was 2.3 plus or minus 0.76, and mean Barthel index was 81.3 plus or minus 13.1. And in the females, the mean anxiety and depression scores were 9.2 plus or minus 3.7 and 6.3 plus or minus 4 respectively. And it was found that 46.6% of these females had anxiety of moderate severity. Coming to the sexual activity, 74% of the participants had attempted sexual activity with intercourse after stroke episode, and lack of interest was cited as the most common reason for not involving in sexual activity by men. And for females, it was like no interest, no desire, or physical limitation. The FSFIS-6 score, around 80% of the females had sexual dysfunction. So the male sexual function by IAF and PEDT, the mean IAF total score was 46 plus or minus 22. So erectile dysfunction was diagnosed in around 42 participants. 53, that is around 62% of the male stroke patients stated that they were satisfied with their sex life, whereas 11 of the female participants were not satisfied. Spasticity was the most common sexual concern raised by men, whereas pain was the most common concern among women. We also done unmet sexual concern evaluation using the questionnaire, and 20 participants felt the need to discuss with someone about the sexual concerns. The male participants were divided into two groups, like erectile dysfunction and those with erectile dysfunction and those without erectile dysfunction. These are the tables. And among the patients with right hemispheric stroke, majority had erectile dysfunction. So this association was found to be significant by applying Fisher's exact test. And Mann-Whitney test was used to explore any association between clinical scales and scores, and no significant association could be found. So people with disability receive little information on sexuality in India. Sexual counseling is yet to become an integral part of rehabilitation. And in this sample of post-stroke patients, 80% of the females and 49% of the males had some form of sexual dysfunction. So, but there is wide variability with other previous studies, and the reason may be the choice of different inclusion and exclusion criteria in the various studies, and different designs of the clinical studies, and different degrees of disability in patients after stroke. And women with stroke sequelae have reported around 77.5% of dysfunction in previous studies, similar to our study. And statistically significant association was established between right hemispheric stroke and presence of erectile dysfunction in this study compared to other studies. In our study, patients reported that their frequency of intercourse decreased from 3.8 times per month before stroke to 2.1 times per month post-stroke. And in our study, 26% of the participants reported to not have attempted intercourse after stroke. So sexual dissatisfaction was reported by 43% of our study participants, which included both men and women. And they state that dissatisfaction with sexual life increased among the patients, with 49% of the patients feeling moderate or complete dissatisfaction. We also tried to explore the unmet concerns. Like 42% of the participants believe there is a need to provide information and counseling on sexual concerns. So coming to the conclusion, sexual dysfunction is a common but often unaddressed concern among post-stroke patients, and post-stroke sexual dysfunction is linked to multiple etiologies, both organic and psychosocial. So further studies with larger sample size are needed to explore the causes of sexual dysfunction and dissatisfaction in post-stroke patients. Limitations: although we established the high incidence of sexual dysfunction among post-stroke patients, the reasons for it could not be explored. So there were multiple independent variables potentially affecting sexuality, but this sample size was not enough to do an effective multivariate analysis. And also, excluding patients with pre-existing sexual dysfunction would have added more clarity to the data, especially given that there are many compounding factors affecting sexuality. Thank you.
Thank you for providing insight to an unaddressed and poorly recognized problem. So the topic is open for questions.
It is not meant to be a criticism. It's meant to be, I hope it will be taken as a suggestion that you will use for your future presentation. Nobody could really see what you were presenting. You were just rushing through your slides. I just couldn't make out what was your final take-home message?
Sir,
No, I understood what it was, but I'm saying that nothing could be scrutinized. You were just too fast, and you need to probably reduce the number of slides and allow people to see what you're actually trying to show. Okay? It's only a suggestion, not a destructive criticism.
Okay, sir. Thank you, sir, for that comment.
Topic: the spinal cord injury and the sexual aspect of that. In our PG days also, seen seniors presenting that. I think it needs a counseling. As I'm not asking question, I think both partners, they're going to be placed together. Everyone will be having a body image once you are getting married. Everyone wants to look the partner beautiful, presentable like that. Beautiful to them and got to be presentable to other persons also. The spinal cord injury after that, we are seeing in our wards, there's some funny things in my PG days, that especially in the stroke patients in middle age, the husband is there, wife will be there, and wife will get friendly with the caregiver of other persons, 2 or 3 incidents they left off the patient. They went out. Such things happen, so that body concept that you go to stress. It is very difficult in a lower socioeconomic status to accept when their husband, because he's not earning, he's not looking as good as before, like that. So it's very complex. The topic you presented as so it's very complex. So it's in a paper presentation is difficult.
Yes.
That is what, so I think he conveyed that. So it's difficult to, within 8 minutes frame.
Yes, 8 minutes was
It's
less
very
for
difficult
me.
to present.
Yes.
Otherwise, it's a very good presentation. Okay. Okay.
Thank you, sir.
One question. You had excluded the patients with previous sexual dysfunction.
Actually, that was not done, sir. That was a drawback. That was a
that was
limitation
not
of the study. Because we didn't, like for the stroke patients, we are asking their questionnaire.
All
so
the
we didn't
stroke
ask,
patients, okay.
so we
You
didn't ask that.
Assess this. That is a very significant.
Yes, sir.
And did you ask about alcoholism and other things, confounding variables? There are many
Confounding variables were asked, but like exclusion, it was not excluded actually.
And you had a correlation with smoking.
Yes, sir.
But did you have a correlation with alcohol intake?
No, it was
You didn't
not.
ask.
Yes, sir.
Okay. So there are so many limitations in the study.
Yes, sir.
And one more thing, as sir said, you are rushing through the slides.
Yes.
We didn't know where you are studied. Which college this study was done?
Sir, this was done in NIMHANS, Bangalore.
NIMHANS.
I did fellowship in neurological rehabilitation there. So during that time, I did the study.
Okay, thank you. Thank you.
Thank you.
So with this, we have finished our free paper sessions. Thank you.
To honor our esteemed chairpersons, I now invite Dr. Arivi TP to kindly come forward and present a memento as a token of our appreciation. Dr. Shashikumar E. Dr. Suraj Rajgopal. Dr. Chitra Ji. Thank you, ma'am.